So when we start talking about hematolymphoid lesions, the most important thing is, how is it going to be treated? So as we classify and as we think about these things, understanding that there are low-grade lesions and high-grade lesions that will be treated quite differently. And then we have to deal with the cases that are sort of in between, the intermediate or indeterminate lesions. We use a lot of stains to classify things. And you can very quickly use many, many stains. So it's helpful to think about patterns and which stains will be useful. So I have listed here several key patterns: small round blue cells with blastic features, tumors that look like lymphoblastic lymphoma or neuroblastoma, very immature, very mitotically active. This group has a longer differential, and so you see many stains here for T cells, for myeloid leukemia, for small blue cell neuroendocrine tumors, for other kinds of tumors, B-cell neoplasms, etc., even small cell carcinoma that could have this pattern. If we have small lymphocytes that are diffuse, like a maltoma or like a small lymphocytic lymphoma, then the differential is smaller and we can use fewer stains. If it has a nodular pattern, then we might use a different set where we would add the BCL2s and the BCL6. If it has plasmacytic features, we would do kappa and lambda. That's what the K and L stands for here. So I didn't mention that. I don't use kappa and lambda very often, primarily for cases that have definite plasma cell differentiation. That's the only time I really feel like kappa and lambda can be helpful. In these other patterns, kappa and lambda is too nonspecific. In contrast, if we have high-grade appearance, large cells, then we're going to do some different patterns of staining based on whether there is any plasmacytic component or whether it's a non-blastic appearance, or if it's a mixture, such as you might see in a Hodgkin's lymphoma or in other tumors that have a bimorphic populations. So thinking about patterns helps us to use our stains better, because these panels might also help us to remember some of the less common things in the differential diagnosis. So I can think, well, usually, Hodgkin's disease, Wegener's granulomatosis, other sorts of things on my differential. But by using a panel, I will pick up other things like neuroendocrine tumors or other sorts of things that I might have not thought about right off the bat. The goal of using immunohistochemistry is really basic. Is it a B cell? Is it a T cell? That's the most important distinction. Sometimes we use immunohistochemistry to identify lymphoepithelial lesions, or we use it to identify bronchi or vessels that have been invaded. That can be useful for this purpose as well. And then to differentiate malignancy. For a low-grade lesion, is there abnormal expression of T cell markers, for example? Or is there B and T expression? Or is it a null phenotype with no B or T? So that can be helpful to define malignant. And then lastly, to differentiate between small lymphocytic lesions like malt lymphoma and mantle cell lymphoma, immunohistochemistry is vital for those kinds of questions. So think in terms of what you need to define when you get this thing. Now there are other tests in immunohistochemistry that can be very useful in hematologic disease in the lung. We use flow cytometry a lot. I know it's not very available in Vietnam. This is helpful because we can do several stains on one cell group, multiple labels, red, green, blue, purple, etc. And yes, so I know that there are a few places where you can get flow cytometry, but do you send samples there? Okay, so you can send them. Good. This is a step forward. We also do cytogenetics to define specific translocations in some tumors using either FISH or routine cytogenetics. And then finally, molecular analysis can be very helpful to define T-cell clonality. And in some myeloproliferative disorders, it's also very useful. Most routine lymphomas, not particularly needed. So, beginning at the benign end, lymphoid hyperplasia can occur in the lung. This is lung tissue, not spleen. And you see the normal architecture here is altered. There is almost a marginal zone and a germinal center here, as you see in this situation. These germinal centers should be hyperplastic type. In other words, the BCL2 mutation will not be present in the germinal center. And if we do a CD21 stain, we'll see the reticulin Langerhans cell network in that germinal center. Polarization. This is a term of some importance in hematopathology, which means that the germinal center has areas of high blastic differentiation and differentiation. So there's a gradient between the high mitotically area and the lower mitotic area in a normal germinal center. You can't always see it, but if you can identify it, it's very helpful to classify the follicle as benign. So the first entity that we talk about here is follicular bronchiolitis. And this is a reactive process with germinal centers, nodules, along this terminal bronchiole. And finding this should raise concern about lymphoma. But if we do the BCL2 stain, we see the germinal centers are negative, and this inflammation is limited to the area around the terminal bronchiole, then we can effectively make this diagnosis. We should not see a situation where it gets larger in size, it extends out into the alveolar septi, or there is destruction, or high-grade cytology. We should not see any Dutcher bodies in the plasma cells, for example. We shouldn't see what's called follicular colonization, which is larger cells, sort of monocytoid cells coming into the follicles in sort of a colony-forming process. And if we do kappa lambda stains, there should be both kappa and lambda in the plasma cells. So this term, nodular lymphoid hyperplasia, used to be called pseudolymphoma. We don't use that term any longer. But it's when we have a fairly dominant lesion, a single mass that has started to look like a nodule. And it still has germinal centers, as you can see here. Oh, this one's totally dead. Okay, so it still has the germinal centers in the nodules, and sometimes we'll have a peripheral rim of fibrous tissue as well. So that's helpful. And it may be along the vascular bundles in the tracheobronchial tree. So what we should see is usually a solitary nodule. It can be fairly good size, but usually less than 5 centimeters. We should see follicles that have this polarization, dark and light, and so forth, and they should be BCL2 and MUM1 negative in the germinal center. We should not see, again, Dutcher bodies, monomorphic cytology, colonization of these follicles, any infiltration into surrounding tissues, or alveolar septi. Lymphoid interstitial pneumonia, LIP, and diffuse lymphoid hyperplasia can be quite similar to this. And we'll talk a little bit more about LIP next time. These patients usually have some sort of altered immune state, HIV, or on chemotherapy, or they are have an autoimmune disease or something like that. And this is a similar pattern morphologically to these other two entities, nodular lymphoid hyperplasia and follicular bronchiolitis. So the cytology looks the same, but it's just more generalized. So with this situation, we can see the alveolar walls expanded and thickened. So this is when it extends out into and involves the alveolar septi, and there can be a gradient movement from one area to the other. The germinal centers that we see should still appear benign and not have BCL2, for example, or other MUM1 cells in there. And most of the cells are going to be T cells. So here's a nice example of what this looks like. You see it is multiple areas. It's involving the alveolar septi and so forth. Now last time when we talked about lung disease, we talked about 6 patterns, you remember? So which pattern is this? One pattern was alveolar infiltrates. One pattern was chronic cellular infiltrates. One pattern was nodules. One pattern was nearly normal. One pattern was fibrosis. So which one is this? This could be either nearly normal or chronic cellular infiltrates. Yeah. More likely chronic cellular infiltrates with the mostly blue cells. Yeah. So here's the chronic cellular infiltrates pattern that I showed last time. Not exactly like that, but close. So what we should not see with lymphoid interstitial pneumonia is any evidence that the architecture is damaged or fibrotic or becoming nodular. We should not see abnormal germinal centers that have this colonization change or Dutcher bodies or any undermining of the vascular endothelium. That would start to lead us towards lymphomatoid granulomatosis. And we usually should not see any evidence of organizing pneumonia in this cases as well.
And Dutcher bodies and Russo bodies, so which is the difference between I can't understand the difference, the two bodies
Yeah.
management ones.
Yeah, so
in this lecture is that should be not those.
yeah, so these are Dutcher bodies, and I didn't bring a good illustration of that. Let me do that for next time to clarify that contrast between Dutcher bodies and Russell bodies, and the differentiation of those. In general, as I recall, and I have not looked at this real recently, well, I probably shouldn't say because I might mistake. So let me do that next time. It's important to understand that the outcome for patients with this pattern can be quite variable, depending on what is the cause. So some patients will do well; they'll get better, they'll respond to steroids. But if they have some associated condition, like renal failure or autoimmune disease or something, those patients may progress and fail due to other problems as well. And then the most important thing is to make sure that this isn't mantle zone lymphoma. So sometimes if you're concerned about that, doing a cyclin D1 stain, it could be worthwhile to make sure it's not mantle zone. So maltoma in the lung does occur as well, and this is an important diagnosis not to miss. It looks different than it does in the stomach or the bowel or in the thyroid, but it has some similarities as well. We usually think of the lymphoepithelial lesions and so forth. Those are not prominent in the lung. So, again, in the lung, we don't know the specific inflammatory or infectious trigger for this disease. It does have the same translocation in many of these cases that we would see in the stomach or elsewhere. So it probably has a similar mechanism, but we don't know for sure. And that may impact treatment, so we don't use anti-helicobacter treatment to treat this in most cases. We will have a mixture of cells, and this is where we do start to get this follicular colonization, and we should have some evidence of clonality. If we see lymphoepithelial lesions, and we may have to hunt for them because there's not a lot of bronchial epithelium, that's very helpful. We shouldn't see evidence of cyclin D1 or CD43 or any sort of large cells that would be suggested by that. So if we did have CD43 expression, what might that suggest? Yeah, so that might be marginal zone lymphoma. And syncytia of large cells could be a different type of infectious process, like measles or other sorts of things as well. So here are the lymphoepithelial lesions, and you can find them that are characteristic of MALT. They're not a mystery. The challenge is making sure we have enough bronchial epithelium that's close to this process to identify them. And you can use either the lymphocyte stain or the keratin stain to demonstrate that they're in the epithelial space here. Diffuse large B-cell lymphoma is another disorder that usually is not a hard one to recognize as malignant, but it may be difficult to classify sometimes as lymphoma, because sometimes we can have pleural involvement, sometimes we can have very epithelioid appearance to this process, and the cells can look almost like carcinoma. These lesions usually present as a mass and may come out of a pre-existing low-grade lymphoma. So this can be a progression from a follicular lymphoma or a high-grade version of malt lymphoma that has developed over time. Usually they will also destroy the lung parenchyma or cause pleural adhesions and so forth. The differential, as I mentioned, includes metastatic carcinoma, Hodgkin's disease, melanoma, and other epithelioid malignancies. So it can be quite an interesting problem. There are several different varieties of the large B cell. This can have a T cell rich form, and then these unusual variants where you have primary intravascular lymphoma that can be very subtle, and then the ALK positive and CD5 positive sort of mixed lineage type of appearance of diffuse large B cell lymphomas. So here's an example of primary intravascular lymphoma, and this is that nearly normal pattern. You see it looks very, very normal appearing. And really only with the immunoperoxidase stain for the CD20 would we be able to demonstrate these very large atypical cells within the vascular spaces. Lymphomatoid granulomatosis. This is a terrible name.
Yeah, so I wonder, it could be a true lymphoma or
So part of the challenge with this, of course, is that it comes in different stages. And so this has a staging scheme that will help us to think about this. At the far end, the high-grade lesions are very easy to define as malignant, but at the low end, these B cells can be very subtle and hard to pick out because there's so many other things going on. The other interesting thing about this is that it can involve other systems, like the brain, bones, and brain and the skin as well. I haven't ever seen a case in the skin, but it's certainly something that would give me cause. And the characteristic feature of this is its angiomatoid character. So it likes to go after the vessels. Here's one where it has really attacked the vessel. Now, seeing this, you could say, well, this is very abnormal, it's destructive. This is a high-grade version. It might be easy to call this a malignant lymphoma. But there can be less obvious versions as well, which might just be vasculitis. And so here's, again, another example of a destroyed vessel with this disorder and the very angiotropic nature. These cells are big. They tend to be large cells, but if there's just a few of them, again, it can be very subtle. Oops. I lost part of my picture here, so we'll skip that. So what should we see? Well, we should see mostly small cells or resting lymphocytes. But there should be at least some CD20 positive and ideally EBV positive large cells. Usually there should be necrosis and some sort of vascular damage that's mediated by these lymphocytes. That's kind of the bare minimum for the diagnosis. We might see the syncytia of larger cells, and we might see CD30 expression. So we might have to differentiate from Hodgkin's disease or from ALK lymphoma and so forth. But we shouldn't see sinonasal disease. This is not a lethal midline, this is not an NK lymphoma. We shouldn't see Hodgkin's disease expression. The granulomas are not well formed. It's not sarcoid or Wegener's. And we should not see very many eosinophils or neutrophils in the background. That would make us think more of Hodgkin's disease. So this is the grading system that I alluded to, and it's based primarily on these two features. How many B cells? Is there necrosis? So grade 1, very few B cells per high power field, very little, if any, necrosis. Up to grade 3, there are large clusters, syncytia of atypical cells, lots of necrosis, and then grade 2, whatever's in the middle. They give you the count, but it's just partially a gestalt process as well. So sometimes in a situation like this, we might need to do a CD20 stain to be able to say, oh, these are the large atypical cells that are positive. What about lymphomatoid granulomatosis? Now, it's hard sometimes for us to think about a malignant process being just a few scattered cells. This is a difficult process to think about. But there are lymphomas that do this. I saw a case just recently in the bowel with just scattered atypical large T cells and a necrotic pattern that would be sort of comparable to this.